In one of the major trials of prehabilitation before cancer surgery, patients significantly improved their strength, endurance, and physical functioning in a 4-week program. And as far as evidence goes, this is just the tip of the iceberg. In this video, I will lay out the coolest evidence we have supporting the success of prehabilitation and provide a breakdown of your entire medical team so you can keep track of all the names and faces and their jobs. This is part of a full series on cancer prehabilitation. You can definitely watch them in any order. But the first video went through a nice overview of how prehab is structured and why it can help. Swing back to that after learning how it can help. So check this out.
All right, so what's the point of doing all this stuff? This section we're going to talk about all the benefits of prehab. I want you to keep these points in mind anytime you're working hard and need a little bit of extra gas in the tank. But again, and I'm going to stress this frequently, this is not something that should be giving you one more source of guilt for not being able to follow through with something. This is meant to just give you a little bit of a boost whenever you have the opportunity, the energy, all that stuff. So just don't feel guilty if you're not able to do some of these things. The whole point of prehab is hope. So don't try and compare yourself to what you should be doing, anything like that. The only should here is just doing your best. All right. With that, let's check out those benefits. So the first clear benefit is improved treatment tolerance. Kind of intuitive. An overall better conditioned, nutritionally supported, well-rested body tends to respond better to treatments, as well as have fewer side effects along the way. And in fact, that's what some of these studies are showing. The first example of this is that a good multimodal program that includes psychological support, exercise counseling, nutritional counseling, programs like these show significant improvements in psychological reserve or just emotional resilience, essentially. And that's a big part of cancer prehab, is just having that emotional fortitude to keep fighting really hard when you need to keep going through both treatment and through rehabilitation in general. This one's kind of broad and very commonly reproduced, but in general, exercise-based prehab programs will improve cardiovascular fitness as measured by VO2 max and general aerobic capacity. Like I mentioned before, this increases general tolerance of treatment, but then also when this translates to a resilience boost, you end up having greater independence and reduced frailty after prehab and after cancer therapies are finished. And that is going to be shown by this study. Another study right here showed that multimodal prehab programs with an emphasis on the nutritional side of things can reduce treatment-related functional decline, which is, again, the whole point of prehab is that when you have therapies, you're going to reduce your functional capacity. So a nutritionally focused prehab program has been shown to actually reduce the amount of the decline, as well as also reducing the hospital length of stay. And the comparison group was the Enhanced Recovery After Surgery program. So in the standard perioperative program as the control group, prehab had an interval benefit on top of that one too. So that's a pretty nice comparison and pretty nice finding to have there as a feather in the cap of prehab in terms of substantial benefit. And that's a great segue into the next category, which is reduced hospital length of stay. And the reason why this is such a priority, there's a few of them actually. The first one being it's great for the patient, both wellness, well-being, mental health, all that stuff, but also reduces your risk of picking up all kinds of nasty stuff that's floating around the hospital. So urinary tract infections, pneumonias, random other infections like MRSA and C. diff, which is a terrible diarrheal illness. All that stuff, the risk goes away when you leave the hospital. So in that case, we want to get you home as fast as possible, as long as it's safe to do so. Now, whenever you're doing something like this, if you can align all the different stakeholders' priorities here, stakeholders being anyone who's affected by the situation, you're going to get buy-in and things are going to happen. So in this case, it's great for the patient, but it's also really good because the insurance providers can save some money when you reduce the hospital length of stay. So you actually might get those ghouls is a wrong word, but get them on your side. And then after that, of course, hospital systems as well, if they're going to buy in here because they're going to save money, whatever, it's still a benefit too. So if everybody's on the same side or something, it can get done. So in this case, if we can make prehab appropriate for everybody, everyone's a winner here, then it might be able to be kind of more commonly included in all kinds of programs, not just core major hospital systems before cancer therapies and organ transplants where it's kind of commonly found now. This is obviously about cancer prehabilitation, may be accessible where you are, but still may not be either optimal or kind of the difficult trek to get there. And so hopefully this video and then this kind of series here will give you we'll give you the resources to fill in the cracks on your own leisure time here. All right. So which studies are we talking about that showed this reduced hospital length of stay? There's no need to go through study by study because they'll kind of show the same thing. These studies all show that 2 to 3 days shorter hospital length of stay following any sort of cancer-related procedure, typically a resection of a tumor or something like that. On top of that, we're seeing in different kinds of cancer as well. So colorectal cancer was one study that found this. Ovarian cancer was another population. And then one large study of studies, a meta-analysis, showed this across cancer types as well. Now, how are people getting home sooner? Usually it's going to be from fewer complications from the procedure itself. These fewer complications range from fewer infections at the surgical site, in which case this one showed a 25% reduction. It's a pretty big deal. 50% reduction in pneumonia rates. And then another study here showed a general 30 to 50% reduction in overall complications. Those are pretty big deals there. So not only are you getting home sooner, but you had less of a bumpy road along the way to get there. So what about outpatient type procedures? Well, in this case, we've also demonstrated that you have reduced chemotherapy and radiation side effects, which kind of brings me to the main point here, which is that prehabilitation is not just working your butt off for some payoff on the back end. During cancer therapies, you're going to feel better along the way because you're just more resilient, able to deal with any sort of stressor that's being kind of thrown at the body. Because to attack cancer, you got to kind of attack the whole organism here. So that's why chemotherapy and radiation give you the negative effects in the moment, but you're more resilient than the cancer ends up being. And so you pull through and then you achieve that remission. That's really important. Some of these benefits are going to be related to treatment-related fatigue, as well as depression and anxiety. And then radiation has kind of its unique constellation of negative side effects and symptoms during, later, after. But one finding in a lot of these studies shows reduced mucositis. So it's inflammation of mucous membranes, which is very painful and can affect a lot of secondary things like nutrition because you don't really feel like eating when everything kind of hurts. Interestingly enough, this improved mucositis often is related to optimizing nutrition as part of the prehab program in particular. So kind of a dual benefit here with nutrition. Improved nutrition reduces the symptoms, and then reduced symptoms allow you to maintain that proper nutrition so you can recover better in general. On top of that, lymphedema is another really important target for improved outcomes when it comes to cancer treatments because that can be quite debilitating if you're not adequately prepared and can reduce it as much as possible. So this study showed improvement in lymphedema, and there are more that will show the same thing. Effectively, a good exercise program is going to reduce lymphedema, and we'll probably bring this up again later, by building muscle to help move that lymph fluid out of the limb and mobilize it back to the heart and circulation so that you can either increase your blood volume or urinate it out later instead when you don't need that extra fluid. And then one last interesting kind of area of curiosity is that there's a lot of research going on trying to find ways of reducing neuropathy from chemotherapies because a lot of them cause different kinds of neuropathy, particularly platinum-based chemotherapies like cisplatin, carboplatin, or chemotherapy agents like vincristine and blasting. Those also notoriously cause neuropathies. And we're going to get into more detail in terms of very specifics in terms of which treatments and which cancers are associated with which negative effects and how prehab can specifically target those. But in this case, there were some small studies that showed potential benefit of medication like oxcarbazepine when used during chemotherapy to reduce the incidence of neuropathy. Now, I don't bring this up because that one medication is unanimously determined to have this benefit, because actually there weren't any studies done after this to reproduce that effect. More along the lines of what the general ethos and heart of prehab is, which is both hope and kind of intellectual curiosity. And essentially what the benefits of a prehab mindset can give you in terms of designing programs with a very personalized approach in mind and using that to affect a big change here that is relevant to one specific patient and not just a whole population here. Because everyone's case is going to be different, everyone's treatment is going to be different, everyone's cancer is going to be different. So finding ways to personally tailor these things is the job of a very capable prehabilitation team leader kind of thing. So extending the thought process of reducing neuropathy pain and those sorts of things, in general, cancer-related pain is a major concern of folks going into treatment because part of the pain is the suffering of not knowing how bad it's going to be, when it's going to hit, can we control it, that kind of stuff. So extending the conversation about neuropathy here, in general, a big goal of prehabilitation is reducing cancer-related pain overall, not just neuropathy-related pain. There are other kinds of cancer-related pain. And a big part of this is the suffering aspect. So the suffering aspect of pain relates to not knowing how long it's going to last, how bad it's going to get, what you can do to treat it. All those sorts of things just amplify the subjective experience of that pain. And if we can improve that through prehabilitation tactics, then we can reduce the impact of that pain, the experience of that pain. So in this case, we had one great study here, published in Journal of Clinical Oncology, that demonstrated that cognitive behavioral therapy, when combined with exercise, could significantly reduce post-treatment pain. So lingering pain after treatment was effectively reduced using this multimodal CBT-based program with exercise. Now, essentially, this all provides an opportunity for controlling pain even before it starts. And so by doing that, there goes the suffering component too, because you have much more agency in this. You have a way of treating the pain and knowing that you have tools at your disposal. In CBT, the idea is to get a better overall understanding of the experience. And also, we saw this in other areas of prehab, I'm not going to include here, where just discussing pain expectations ahead of time and educating patients on what is normal versus abnormal amounts of pain made that normal pain less of a pain. People just kind of felt better. It wasn't a big deal because they at least knew what to expect. It's a surprise, especially when it comes to pain, that makes it that much less bearable. And that's where prehab comes in, the educational component of prehab. The final cool piece about this one too is that by having less significant pain, patients were able to use less pain medication. Pain medication has its own side effects. So the dominoes benefit here of what you can do by addressing the pain early in terms of long-term wellness is pretty significant and meaningful. As I've kind of stressed a few times, any form of prehab, whether it be for joint replacement or cancer therapies, is work. And work isn't always fun, but the idea here, especially in the case of cancer prehabilitation, is that you're front-loading your discomfort. You're taking this discomfort, bringing it earlier when you're a little better equipped to handle it just because you haven't gone through treatment yet, and bearing that burden then to reduce your burden later. And by doing so, it's like putting money in a savings account. You're going to miss the money a little bit in the beginning, but you're real glad about having that at the end. So in this case, you're real glad about not having that pain at the end or the other effects that prehab is providing you. I mean, in this example here, we have data suggesting that prehabilitation programs can improve overall quality of life, including physical, functional, emotional health during cancer treatments. So what prehab is allowing you to do is to maintain a more normal life, that normalcy. In doing so, the suffering is just improved because things don't feel quite as off kilter. You are able to maintain your normal social circles a little better, or interactions with their family, and so don't have the compounding discomfort of all the treatment, all the uncertainty over prognosis, and then the alienation that can come from that instead. So here is that benefit too of just maintaining that social component as part of prehabilitation and paying the dividends later in terms of during treatments. And we saw that more or less again here. It showed that prehabilitation allowed individuals to maintain their social engagement, better social functioning, and role fulfillment during the treatment journey compared to standard of care. Okay. So I hesitate to mention this one for a few reasons. Number one, I don't want to provide false hope. I think going back to my intro for this section and the whole course in general, I don't want people to feel guilty. So in this case, I don't want someone thinking that they've missed out the opportunity to achieve remission that they've missed out on because they weren't able to buckle down and find the motivation for prehabilitation when they were just way too sick to do so. This is all supposed to be net benefit. So let's keep that caveat in mind. But prehabilitation does have the opportunity to potentially improve overall treatment outcomes, achieving remission, better disease-free quality of life afterwards, so more time before recurrence, all different ways of kind of looking at the same thing. Better healthy time, less time with cancer in your future. And really, we have some studies suggesting this, but we just know what the risk factors for cancer are, and it's typically metabolic health issues, and know that prehab does definitely improve those things when done correctly. So we can say without a ton of concrete data tracking this outcome, I'm sure it's coming, just it takes time to build this longitudinal data set, that improving metabolic health through prehabilitation likely improves treatment outcomes, remission rates, reduced recurrences, any way you kind of look at it. In this study here, prehabilitation showed improvements in disease-free survival in patients after colorectal cancer treatments. Now, some of this is going to be due to both the long-term recurrence, remission rates, all that kind of stuff, but also the short-term, because short-term treatment complications will also affect those long-term outcomes. In terms of improved outcomes, researchers kind of speculate it's due to a number of reasons why. Obviously, if you're going to reduce recurrence rates and the flip side, improve remission, that's all going to improve long-term survival and outcomes that way. But also, don't forget that if you're able to improve your tolerance of treatments, you're going to do more of the treatments. And that's also going to be the reason why remission and things like that is improved. But also fewer complications along the way too, opportunistic infections that put you at risk for really negative outcomes too. So the survivorship benefits don't just come from immediately fighting the cancer, it's also avoiding the bad stuff too. But specifically, exercise does have a number of anti-cancer benefits, as noted here. These include improved immune system functioning. So your immune system is huge in fighting cancer, hence immunotherapy being such a big new area of interest when it comes to research in fighting cancer. Improved blood sugar control. So that goes towards both the immediate infection risk. Less bacteria food floating in your bloodstream means fewer infections where that bacteria may be introduced, such as surgical sites and things like that. But also, by controlling blood sugar, you're going to reduce insulin levels. And reducing insulin levels theoretically reduces stimulation to cancer in terms of growth pathways. We're going to cover that more later, though, so hang on to that one. Exercise also has anti-inflammatory effects, which is really important, too. Inflammation also fuels the fire when it comes to some of the metabolic contributing factors to cancer development and progression here. So by controlling inflammation, you're going to directly have that benefit, but then exercise is also going to have that immune system benefit too. So the two of them kind of work in tandem, complement each other in terms of their anti-cancer effects. Finally, on top of improving insulin resistance, exercise can improve leptin resistance. Now, I know some of the astute folks out there might be thinking, wait a second, reducing leptin levels, I thought leptin was a satiety hormone. Actually, leptin has a pretty similar analogous pathway to insulin resistance, where even though insulin itself lowers blood sugar, insulin resistance is a situation of high insulin levels because the body is not responding well enough to it. Leptin, similarly, even though it's a good thing in terms of controlling appetite, it also, when your body becomes resistant to its effects, you have higher and higher levels of leptin, and those higher levels are implicated in some cases of cancer, particularly breast cancer. Now, that's not all the benefits in terms of how prehab can benefit cancer therapy outcomes and treatment tolerance and all that stuff. This is just a handful of ones I found to illustrate the point. Essentially, we have new studies coming out daily, it feels like, in terms of the benefits here, and you just need to build a program around one specific cancer type, personalize it well enough, and then test that one. So that's why we don't have them all at our disposal now. Also, some of the long-term benefits take a long time to come to fruition, so we can't have those at our disposal as prehab is just starting to snowball and really get that attention it deserves. All right, so let's check in on the cancer types, and then after that, we'll get into something called paraneoplastic syndromes, which is really important in terms of recognizing some of the other effects of cancer and ways that you potentially can address those complications.
So forgive me here, but I'm kind of obliged to do my worst impression of a comedian doing an impression of Jerry Seinfeld when I say, who are these people? So in this case, you're looking around the room and seeing all the different medical professionals involved in cancer care, and probably curious what the heck an oncologist versus surgical oncologist versus a radiation oncologist versus a physical therapist versus a physiatrist versus a... Let me walk you through them all, okay? Alrighty. So the first person on the team that you're probably most familiar with here will be a medical oncologist. This is who you think of whenever you think of oncologist. These are the folks who are going to be prescribing chemotherapy, immunotherapy, and other systemic treatments to try and take out the cancer non-interventionally. They will be often coordinating with the rest of the team, kind of a quarterback type perspective when it comes to the treatment specifically, versus your physiatrist or prehab specialist, which if you have one, might be coordinating things in terms of the preparation period. All right. So the next one's going to be a surgical oncologist, and this part probably is fairly self-explanatory, but they're going to be surgically removing tumors. If it's something like a leukemia, you're probably not going to be seeing one of these folks. But for solid tumors, especially earlier stage, when you have the opportunity to potentially go for remission with resection being the surgical removal of primary tumor here, then you'll be seeing a surgical oncologist, and likely on the earlier side. One thing I mentioned in the book pretty frequently back there is that we're starting to see in the research, there's a survey of thoracic surgical oncologists regarding their perspectives on including prehab, even if it means delaying removal of certain cancers. I believe it was lung cancer. And there's increasing acceptance of this, knowing that as long as the delay isn't too long, oftentimes you'll actually have better outcomes because of the prehab, despite that delay. Next will be a radiation oncologist. So the point of radiation is that by kind of in the same way that radiation in a non-cancer treatment kind of sense causes DNA mutations, and that's how sun exposure causes increased risk for skin cancer because it causes mutations in the DNA of our skin cells. Radiation oncologists do this deliberately. So they will focus a beam of radiation at a cancer site and try to induce mutations that make this, even though cancer thrives on mutations initially, sometimes it becomes even too much for them, and then these cancer cells will die. Radiation is a targeted therapy similar to surgery. The considerations here are going to be based on the extent of the tumor burden, and of course the location. So some respond better than others. Sometimes they'll do radiation as a palliative treatment. So if you have something like a bony metastasis, so cancer that's gone to a bone, radiation can actually reduce the pain sometimes associated with that. So there are many reasons that radiation may be part of the treatment plan, and the impacts of that and the targets of that and the goals of that are going to be different case to case. So this is where the radiation oncologist will bring their expertise and can both improve outcomes as well as kind of the subjective experience during the whole treatment process. Alrighty. Next one is near and dear to my heart, cancer physiatrist. So a cancer physiatrist is a physiatrist, a physical medicine rehab specialist like myself, who focuses specifically on the prehabilitation period, function during cancer treatments, and then post-treatment recovery afterwards. So they do all the stuff we've been talking about this entire time now in terms of helping prepare folks for cancer treatments. But then afterwards, as you're starting to recover back to kind of your prior baseline or your new baseline, identify areas of lagging recovery essentially and target treatments towards that. So in this case, common situation would be after breast cancer procedures, and you may have lymphedema and fibrosis. Cancer physiatrists are going to be experts in managing these conditions, working with physical therapy, discuss their role later in terms of regaining function and also kind of mitigating any other secondary issues later. Cancer physiatrists also are pain management specialists. So in general, during our PMR training, we learn how to do interventional procedures, and so injections into joints, managing oral pain medications, sleep optimization. Again, kind of everything we talked about here, cancer physiatrists or physiatrists in general, that's part of our training so that we can help just improve overall function, recovery, and quality of life. Physical and occupational therapists. So physical and occupational therapists, their role is going to be more towards regaining physical function, of course. So physical therapists are going to help with gait training, prosthetic training, if you're going to be in the line for a prosthetic. Obviously, any sort of musculoskeletal dysfunction. So we talked a lot about scapular dyskinesis and improperly moving shoulder blades and the secondary problems that can cause. Physical therapists will be targeting these kinds of issues and helping to retrain muscles and your control over them and all that stuff. Occupational therapists, they focus more on activities of daily living. So this is going to be all the movements and finer patterns of movements with hands and limbs and everything involved with brushing your teeth and taking care of household tasks and utilizing adaptive equipment. So both therapists will work with you in terms of how to use a cane and things like that, whereas occupational therapists may focus more on lymphedema wraps and gloves and things like that. Of course, they both do that to some extent. There can be an entire separate discussion on the two, kind of the synergy between the two roles here and their unique domains, but just generally, you can break it out into OT will focus more on those ADL tasks, self-care, household maintenance, medication management, finance management, that kind of stuff. They do some of the cognitive evaluations as well. Speech therapy shares that with them as well sometimes too. Whereas PT is more towards larger movement patterns, walking, things like that. Okay, so dietitians and nutritionists kind of do what you'd think they would. They're going to be focusing on optimizing nutrition before, during, and after cancer therapies. They're monitoring for signs of malnutrition. We discussed that at a different point during this discussion. I don't even know if it's going to come before or after this recording, but basically they're going to be looking for changes in weight or just general subjective intolerability of eating, and they're going to be recommending different nutritional supplements to overcome those issues. We're just obviously focused on identifying what sort of deficiencies might be common with certain treatments or just lack of eating because of all the nausea that goes along with this, and finding ways around that. So when I was working on the inpatient rehab side, I worked pretty hand in glove with our nutritionist team as well as the therapy team and trying to figure out the best way to lift a person's kind of capabilities and motivation and function up higher by bolstering nutritional kind of wellness as well as their physical wellness. And then my additional role there was to kind of optimize them medically so that they can perform better in their therapies and they can better get the nutrition they need and all those sorts of things. So the whole team works really, really in an integrated sense. And nutritionists are a critical portion of that one too, because lack of energy, lack of recovery, the rest of the team, our roles fall apart in that respect. Okay, so psychiatrists and psychologists, neuropsychologists, etc. The first distinction is psychiatrists versus psychologists. Psychiatrists are the ones who are MDs or DOs or NPs, PAs, and have prescribing authority. So they're able to, and this may have changed in terms of independent practice changes with PhD side of things with the psychology, but we'll assume the distinction is still separate here. So in this case, often, not always, there is less of the talk therapy, more of the kind of biochemical targeting and use of different medications to try and treat underlying issues of depression and adjustment disorders, PTSD, etc. So as we talked about a few times here, stigma and depression are going to be huge negative risk factors for outcomes. So if you going into treatment have this stigma and shame of I did this to myself, or just run-of-the-mill depression, or you're dealing with still coming to terms with the cancer diagnosis, working with a psychologist or a psychiatrist is going to be really important for getting past that block and being able to focus most intently and most intensely on just getting through treatment and doing your best there. So that's why it's really important to have psychological support, just so that you're not being held back by something that we can modify and get the most out of everything else afterwards instead. Psychologists are more on the side of CBT and DBT and all the different therapy styles. CBT standing for cognitive behavioral therapy, DBT standing for dialectical behavioral therapy, and other therapy styles as a means of working through either past traumas or all the different potential psychological situations here that might be holding back progress as well. So often, of course, there's a synergy between addressing something with medications biochemically, as well as working through something with more of a therapy style. Research on depression, of course, suggests that the both of those together work better than either alone. Newer research on things like MDMA for PTSD show that MDMA works better with therapy, not without it. When you get towards the end of life considerations in cancer therapy, say you've been diagnosed late stage or you have a recurrence or something unfortunate like that, then palliative care and psychologists, psychiatrists may be working together or kind of part of the same team, even for some of the existential kind of concerns that you have towards the end of cancer treatment. In these cases, depending on what state you're in, you may be offered something along the lines of either psilocybin or ketamine or things like this that can help remove that fear of what comes next kind of thing. That's kind of still fringe, cutting edge area, but the research is compelling in terms of the ability for someone who's ready for an experience like that, ready for a psychedelic experience, to have that existential fear kind of washed away from them. And while you're not looking forward to that next step, you are less afraid of it. And that makes just the rest of your present existence that much more enjoyable and present. So I'm a big believer in that area of research and kind of what opportunities it can open up in terms of just quality of life. Quality of life is a big area of focus for physiatry, and that's why I really look for other ways that integration with other team members can improve quality of life, even if it means handing over care out of my direct purview here to someone else who can pick up the ball and run it downfield for us. Okay, respiratory therapist. So respiratory therapy is another really important team member on the inpatient rehab side, but of course on the cancer prehabilitation side of things. Certain kinds of cancers are going to be much more amenable to pre-treatment with respiratory therapy. Obviously anything involving a thoracic surgery, because then you're going to be impacting your ability to take deep breaths and expel air and all that stuff. And anything head and neck because of the swallowing impact. That's going to be a mix of speech therapy and respiratory therapy. And being able to adequately respire is going to give the rest of the system here adequate oxygenation. So that's important, of course, for being able to do your therapies. It's going to be important for sleeping well. If you have any sort of sleep apnea, getting that addressed early, your respiratory therapist can help to kind of work with the sleep specialist in optimizing CPAP therapy, BiPAP therapy, things like that. But the respiratory therapist will also give you exercises for strengthening the muscles involved with breathing, as well as different strategies for expelling anything that's been aspirated. So anything that goes down the wrong pipe, your respiratory therapist can give you exercises for coughing that out easier and avoiding any sort of pneumonias, because not only are you at a higher risk just during procedures, because you're not going to be having that strong cough as you're recovering and have staples and sutures and stuff, or other postoperative pain, but they're also going to then help with suctioning and just helping to retrain patients after these procedures to be able to breathe comfortably and avoid any sort of future risks of pneumonias and stuff like that. There's also a concept called atelectasis, and that's just lung collapse after a procedure. In those cases too, being able to take nice deep breaths and train those muscles so you don't have shallow breaths that kind of foster infection and atelectasis. Those are just important techniques that respiratory therapy can teach you pretty easily. Palliative care team. So everyone has kind of heard the term palliative care, and it means a lot of different things to different people. They do a lot of pain management as well, kind of mood management, anxiety management, end of life care, goals of care planning. So going into this whole process, it's good to have kind of before you get in the weeds, where is your off ramp? Where are you done with this whole thing? What is the outcome not worth the potential treatment to get there? And these are important considerations to have before you start getting into actual treatment, because once you're kind of face pressed against the painting, you're not going to see all the details. And so you may be persuaded to kind of get extra inches in terms of potential quantity of life at the expense of much larger quality of life. So having the conversation ahead of time, then periodic kind of revision of this with a palliative care specialist will make sure that you're not putting yourself or your loved one through unnecessary, uncomfortable situations just to try and eke out a little bit of extra time. But the time itself is worse than if you had just kind of, made yourself well and comfortable and all that stuff instead. Palliative care teams may have, caseworkers, psychologists, or someone else with whom you can sit and talk and just kind of think out loud and identify what's important to you, functions that are important to you, future events that are important to you, and strategize how to optimize yourself for that purpose. So palliative care is critical for really getting, again, the most out of the time you have and being with family and being comfortable and present as much as you can. So the biggest regret a lot of people have is not involving palliative care sooner. So it's really important to, even before there is a terminal diagnosis, even if there is a chance, even a good chance for remission, it's still important to involve palliative care just so you can start building a relationship and they can help just kind of be your sounding board for decisions along the way. They're very nice people usually. All right, and the final one that we're going to talk about here today will be your social workers. They're going to help connect you with resources and support services, either financial resources or transportation, or coordinate care in terms of, work release notes, and really just making sure that all the little things don't fall through the cracks so the big plan moves forward. Oftentimes they're kind of the point person. Say you're in inpatient rehab and they're connecting you with all the outpatient care. Your social worker team is going to be a big part of that, as well as the nursing staff and those folks. They're going to help you find resources for financial support, for transportation support, as well as support groups. Also very friendly people. So love our social workers. Okay. So this is not the complete team. As always, there are many other professionals that may be involved here, but hopefully this kind of sorts out some of the main folks a little bit. If I missed anybody, please let me know. Otherwise, see you in the next one.
Thank you sincerely for hanging with me through all those details. Again, please like and subscribe so others can find this resource during their cancer journey. If not already, the next video should be up within a week, and that one will be covering cancer-specific battle plans for each type of cancer. I know I struggled with this one when I was first getting started in my training, so I'll break it down for you nice and easy.